everyone, to our University of Colorado Denver College of Liberal Arts and Sciences series, Conversations about COVID. I'm Marjorie Levine Clark, and I'm a professor of history and associate dean for diversity outreach and initiatives in the college, and I've been moderating this great series. Some of you may have attended our series on COVID-19, Colorado and beyond last summer. We had a lot of questions at that point about what the future was going to look like, what the impact of vaccines was going to be. And we're in kind of an anxious moment right now with powerful virus variants and low vaccination rates in a lot of places. And some cities are going back to requiring masking indoors. Only recently, many people were feeling pretty confident that the pandemic was over, but now some are expressing concerns, more concerns about safety. Today's lecture, I think, will help us understand some fundamental elements of these anxieties. All the lectures in the series are recorded, and you can find them on the CLAS YouTube channel, usually on Friday. And I think Tracy is going to put the link in the chat. So for some Zoom etiquette, I think you all know to please keep yourself on mute for the duration of the program. And please use the chat feature to ask questions. If we're a small enough group, we can just ask questions by hand raising at the end, and we'll try to get to as many questions as possible. I want to thank our outstanding faculty who volunteered their time for this series. And I also want to thank Tracy Combe, the CLAS Marketing and Communications Director, Tim Stalker, our CLAS Webmaster, and Kristen Salisbury, the Program Manager for CLAS Continuing and Professional Education, all of them for their help on the technical side of putting this series together. Our speaker today is Jennifer Reich, who is a professor of sociology and director of the University Honors and Leadership Program. She's the author of 2 award-winning books, Fixing Families, Parents, Power, and the Child Welfare System, and Calling the Shots, Why Parents Reject Vaccines. She's also editor of the books Reproduction and Society and The State of Families. Her work has been featured in media outlets, including the New York Times, the Washington Post, NPR, and Newsweek, and on the Netflix show Bill Nye Saves the World. She teaches classes on healthcare, family, and reproductive politics. Her lecture today is Vaccines Against COVID, Politics, Policy, and the Challenges of Protecting Communities. Welcome, Dr. Reich.
Thank you so much. And thank you all for joining in mid-July, which is always hard. This is since last year, a lot's changed and also maybe not enough, but this will give us a chance to sort of see where we are day to day. What I found right before COVID is that I was writing about vaccines and talking about vaccines just as people were starting to think it was a little bit interesting because we had a measles outbreak at Disneyland. But I keep thinking lately about the grant I wrote to fund research on parents making decisions about vaccines, and had somebody reject the grant with a note that said, like, who cares, what parents do about vaccines. And I think I couldn't have imagined ended up spending the last decade to get to where we are now. Having studied pandemic response and vaccines and outbreaks, I lacked the imagination that we would still be here a year later. Part of what I find in my research generally is that we think about decision-making about our health as entirely personal responsibility. We talk about counting your calories, counting your steps, eating a rainbow a day, and we consistently message that your health is your responsibility. And of course, the problem with this is that it assumes that disease avoidance is also entirely within your control. And this is not just in magazines and on, say, Jillian Michaels' training show. This kind of messaging occurs from public health agencies that, a couple decades ago, stopped focusing on community level interventions and really retooled around personal behaviors, whether it was smoking cessation or jogging in the 70s. Public health really became about personal behaviors and individual interventions. And so what I argue generally is that this has set the stage perfectly for us to see declining consensus about vaccines. At the bottom of vaccine decision-making, over and over again, people tell you it's an individual and personal choice. And what all individuals are weighing, and I found this with parents, and it's equally true with COVID, vaccines for adults, is that people are weighing their perception. So this is not the mathematical risk calculation, but rather their perception of risk and benefit of the vaccine stacked against their perceptions of the dangers or risks of the disease itself. So they look at how safe do they believe the vaccine is, how serious is infection, how well do I think I or my children will handle infection. So with children, I saw families that fully vaccinated maybe one child, did some vaccines for another child and rejected all vaccines for a different child on the assumption that each child or each body can handle something different. But also what during COVID is this question about how well will I handle infection? How serious do I think infection will be compared against my concerns about the vaccine? Will I have to miss work? How does this align with my other goals? What does it facilitate in my life? And at the bottom of all of this is the assumption that individuals see themselves as experts on their own lives, their own bodies, and their children when it comes to childhood vaccines. And that vaccine decisions draw on this kind of individualized and personalized understanding of health and illness. The challenge with this, of course, is we set the stage several decades ago, and it's a mismatch to responding to a pandemic. We don't have any kind of real understanding of what it means to have a response at a community level. And when it comes to infectious disease, what we've learned exquisitely well during the last year, but which has always been true, is infectious disease is beyond individual control. You can make all the right choices and do everything right, and you cannot completely control viral transmission. And yet we really are struggling with this kind of messaging that really brushes up against our understanding of health promotion as a personal responsibility. As a reminder, for the last year, we've seen rates of COVID. And so here's just a quick overview of where we started and where we got to at the time of vaccine. So March 2020, when we were all going to take an extended spring break and maybe come back in person, which seems so quaint today. March 2020, we saw about 56 infections per 100,000 residents. And you can see how rapidly those numbers increased until we get to December, which is the beginning of our use of vaccines against COVID. We had 2 vaccines authorized in December, which we'll talk more about. And you can see the ways the vaccines had a dramatic effect in terms of turning the tides on infections. At the time COVID started, these memes showed up everywhere. And as someone who'd been studying vaccines for a long time, I found it really fascinating that this was some kind of moralizing lesson for anti-vaxxers. For people who oppose vaccines, here's your demo version of what a world would look like. And the assumption was as soon as we got a vaccine, this would all be solved. Vaccines are largely seen as magic bullets. And for many of us, we haven't grown up in a world with widespread infectious disease that are now vaccine preventable. Most of us are too young to remember the polio era, or even to remember what it was like to have tens of thousands of cases of measles every year. And so to think about what this means at this moment, this is the kind of snarkiness that we saw setting the stage for the introduction of vaccines against COVID. To note, we've all learned more about the clinical trials process than I think any of us ever thought we wanted to know. But as a quick reminder, vaccines are developed first with very basic lab science. They're subjected to animal testing and different kinds of models. And if things look good in a preclinical setting, we see clinical trials. And as a quick reminder, phase 1 enrolls a handful of participants, and it's only looking at safety. Is there safety from this medication or this vaccine or this intervention? If it looks like it's safe and there's some promise, then we'll move to phase 2, which is an effectiveness trial, which might enroll a few hundred people. And it's looking at both the effectiveness of the intervention and also what the kind of dosing might make sense. To figure out at what dosing levels we might see a response. And then phase 3 is where we get to this notion of safety and efficacy. And that's where we see tens of thousands of people enrolled, as we did in the COVID vaccine trials, where we saw most trials have about 30,000 participants, which is a really large trial. These phases typically happen sequentially, and there's usually time between each trial for scientists to take a look at the data and decide what's happening. And if it all looks promising, all of those data are submitted to the FDA for approval under what's called a BLA, which is it's a new biologic licensing application. The FDA reviews it, they approve a new vaccine. When we have approval of a new vaccine, that vaccine goes to the Advisory Committee on Immunization Practices, which is an advisory committee of people who do not work for the government that advises the CDC on recommendations. And they're separate from the FDA and they are separate from the government. We have several ACIP members in Colorado because we have pretty vibrant vaccine research here. What happened, which is really unusual, is that we saw these processes collapsed in pursuit of a vaccine against COVID. So we saw that the phase 2 and 3 were overlapping. In other words, it looked promising enough in phase 2 that scientists began enrolling participants in phase 3 before phase 2 data were complete. And typically we wait until after FDA review before manufacturing begins. What we did during COVID is we spent lots and lots of federal money to do what's called at-risk manufacturing. We began manufacturing vaccines without any data to show definitively that it was safe and effective so that we would have a stockpile should the clinical trials work out. We also saw the use of an emergency use authorization, which is emerged out of the anti-terrorism post 9/11 laws. So it's only been law since 2004, and it's only ever been used on one other vaccine, which was the vaccine against anthrax. So the emergency use authorization has a slightly lower standard of evidence in that it has to appear safe and effective rather than be definitively safe and effective. And it has to be a solution to a life-threatening situation for which no alternative exists. And it has to be the result of a public health emergency. So in theory, if no vaccines are fully licensed at the FDA and the public health emergency expires, the vaccines would go away. So it still requires a BLA. That application process at the FDA has to continue. But what we saw with the emergency use authorization is that the CDC Advisory Committee weighed in to make recommendations for us on how the vaccine should be used and by whom, which is typical. And that's how all pediatric vaccine schedules are set, for example, or the flu vaccines are evaluated each year for safety and efficacy. So we saw one year, if you recall, the nasal flu vaccine was taken off the market because it was not effective when they added a fourth strain of virus to the vaccine. So the ACIP meets several times a year. Their meetings are public to discuss how to advise on those usage. Once the CDC commissioner publishes their recommendations, they become the things that cue things like insurance reimbursements and state laws for vaccine requirements. And then what's really important is we have a phase 4 we never think of, which is vaccines have the best post-approval monitoring and safety system of any pharmaceutical product. And what we have on that front is we have multiple data systems. You'll hear a lot about VAERS, the Vaccine Adverse Event Reporting System. This is a voluntary reporting system. Anybody can make a report, a family member, a doctor, a patient, anyone can make a report of an adverse reaction. And this is what people call a hypothesis generating system. There's a lot of junk in VAERS. People die in car accidents following vaccines has been reported. There's one famous report of someone getting green and muscular and turning into the Incredible Hulk after vaccine. Anyone can report anything, and there's no denominator for VAERS. It's a voluntary reporting system, but it's really helpful to look for signals of something that might be happening that can then be looked at more in more detail. So we have other data systems. We have the Vaccine Safety Data Link, of which University of Colorado is one of the sites that we study. And that looks at tens of thousands of health records, and it looks for things like an uptick in emergency room visit after vaccination as a signal that there might be something happening. And then there's the ability to go analyze data systematically and look at case data. And FDA has its own system, the Sentinel system, which is actually more limited on vaccines, but it covers all medications and pharmaceuticals. And these data systems that exist in the background are really important. They've identified really small outcomes. So when you think about the pause for the Johnson & Johnson vaccine that happened in April, there's something amazing about identifying 15 cases out of over 3 million vaccines in a matter of 2 weeks that happened because of these data systems. No other pharmaceutical product has that kind of real-time monitoring that vaccines do. This is really important because we give vaccines to healthy people, not sick people. So the standard of safety is much, much higher than it would be for other pharmaceutical products because we're introducing risk in healthy people, which is different than curing illness. And that really matters. Some research from April of 2020, so before there were vaccines, said that it was either over 95% of Americans said it was really important and that they would be willing to wait longer for a vaccine to make sure the clinical trial process was rigorous. So where we are as of this week, there are 52 vaccines undergoing safety testing. We have, they're in various phases. 5 turned out not to be successful, including one by Merck, which everyone was really optimistic about early on. We have in the US 3 vaccines that have been authorized, 2 in December of 2020, 1 in February of 2021. But it's worth noting that worldwide, other vaccines have also been authorized in other countries and have not been used in the US. AstraZeneca being one of them, but there's several others as well. And I'll just highlight Novavax has had completed clinical trial data for a long time. Their data look really good. They have not submitted completely for licensing, and no one's really quite sure why. But that's a third vaccine that I think people are expecting the US to have access to should we decide we need it. The goal of all of this is to create community immunity. So there's some individual protection of vaccines, but what we're really going for is what people call herd immunity. So just really quickly, if you think about the red people in the diagram as infected with, say, COVID or any other vaccine preventable disease, and the blue people are unvaccinated, either by choice or because they're too young, as we're seeing with COVID, or they have an autoimmune disease, or they're the recipient of a transplant that's immune suppressing, or for whatever reason they don't generate immunity, they're vulnerable to infection. So our goal is to be the green people that create essentially a firewall between the people with infection and the people who are vulnerable. And we can only do that when we have a critical mass of the population fully immunized. When we started with the vaccine development process, we had the ill-named Operation Warp Speed. And what's really important to note about the Operation Warp Speed is there was money infused into pharmaceutical companies, either because we pre-purchased vaccine for manufacturing should it work out, or because we gave money for research and different companies had different configurations of contracts. But what's important to note is there was never really a plan on distribution. So where my red arrow is where we go from a contract with Federal Express to magically vaccines end up in hospitals or large organizations or pharmacies or long-term care facilities or doctors' offices, which still hasn't happened, or Indian health services or public health clinics, or, and there was no mechanism by which vaccines would get to those places, or more importantly, how it would get to the people who needed the vaccine. So there was never an imagination for having a ground game within the federal mechanisms. And we saw that in the initial rollout of the vaccine. What we also saw is that the vaccine rollout, as it took up some steam, became really popular. So here's a time between basically the end of December through January, and then all the way through to where we are this week in July 20. And what you'll see is there's a large variation between initial enthusiasm and what we've seen is a drop off in interest or use of vaccines. So where are we now? In the US, as of this week, we have about 56% of people in the US who have had at least one dose and about almost 49% who are fully vaccinated. You can see it broken down by age groups. Just as a reminder, Pfizer is the only vaccine that has been authorized for the use from 12 to 18-year-olds. Moderna starts at 18. And then at the bottom, here's where we are in Colorado. And we are doing slightly better than the national average, though not as well as the governor's press conference today might indicate. What we see is that there has been some variation by manufacturer, but that the line have been pretty consistent. So there's not like everyone's rallying around Pfizer and dropping the other ones. The lines have stayed in parallel, reflecting the kind of use patterns. The only exception being Johnson & Johnson, which had a pause in April and then has been pretty slow to return. They've also had a ton of manufacturing problems, if you recall, in terms of its supply. Why all this matters is really interesting. So when the ACIP made their initial recommendations way back in December 2020, you might recall, this seems really quaint today, we had these like different priority groups. And what these priority groups represented was two conflicting goals. So on one hand, there's a goal to save lives, and that is where vaccines went first, to long-term care facilities or to persons over 75 years or older. But there was a simultaneous goal to also keep core institutions running, which is why healthcare personnel were front of the line, or why essential workers were front of the line. And what we saw within 2 weeks of these recommendations is that 70% of states had already abandoned following them, that we saw states creating their own priority groups, and that there were huge disagreements about which institutions or which workers were essential and how that priority group should matter. And I'm raising this because it's predictive of things we didn't anticipate. So one is that if you're white, you live longer. So when we prioritized older people, we were more likely to capture white seniors than any other racial or ethnic group. And so inadvertently, that we could have made this a vaccine for groups that were most affected by the pandemic. We could have prioritized in lots of ways, but by solely going after age, it became a race blind kind of way that ignored the fact that the virus has had very different impacts in different communities of color. We also know that vaccine hesitancy clusters. So knowing somebody who's been vaccinated increases your chance of wanting a vaccine. It makes you more trusting. So as of February 2021, so if you recall, the priority groups were around January when it started, January, February, it started opening up to all adults. What's really informative is that the gray line is you don't know anybody who has gotten a vaccine against COVID. And the dark blue on the far left is you know someone who's received at least one dose. And the middle is a household family member or close friend. And what's really important to note is that you were so much less likely to know anyone who had gotten a vaccine if you had a lower income, if you were not college educated, or if you were Black or Hispanic. And by prioritizing healthcare workers and seniors, it made it possible that very few white people didn't know anybody. Only 7% of people with making over $90,000 a year didn't know anyone who'd gotten a COVID vaccine. And this actually magnifies in ways that are invisible because knowing someone increases your trust of the vaccine and your interest in getting one. And so this had farther reaching effects than I think ACIP knows. If we look today at who's not getting vaccinated, you'll see a couple really stark patterns that have held true for most of the pandemic. Young people mostly don't want the vaccine and they're not getting it. And some of them are saying they definitely don't want it, which is the green side on the right side. But the wait and see group has remained the youngest people. People over 65 understood clearly they were at high risk of the virus and they were the first to get it. We have very high vaccine rates over 65. What you'll also see is that despite our important discussions about racial disparities in access to vaccine, and we saw lots of discussions of Tuskegee that we hadn't seen in many, many decades that are really important for thinking about trust and racism in healthcare systems. But what's really notable is that people who are white are the most likely to not want a vaccine and to want to wait and see. And that is significantly associated with partisanship and education level. Of the reasons people say they want to skip a vaccine, the number one reason is the vaccine feels too new and they're worried about side effects. And there's some about government trust. I was part of a paper that just was published recently that we noted that even if you control for trust in government, the partisan divide does not go away. The partisan divide appears to be about identity and membership more than serving as a proxy for other factors, which is interesting. The percentage of people who say that that they're somewhat concerned about each of the following comes down that you can see these tracking also across racial groups and that the same kinds of questions that have good answers. And so among those who have not been vaccinated, these are the answers they gave about why they're not vaccinated. They're not convinced that they're safe. They might have serious side effects. It might affect fertility, which has been a really persistent concern. The side effects might make you miss work. So that's not a kind of conspiracy theory. That's a very material concern about access and availability. We also know that we have a surprising number of people who are partially vaccinated. It turns out only about 88% of people who were eligible for a second dose had received it by June 16th. And that's lower than it was earlier this year when about 92% of people were coming back for a second vaccine. That means we have almost 15 million people who have not received their second dose. And that matters a lot, particularly as we're seeing more variants, because the efficacy of the vaccines goes up significantly. One study estimates from 33% with one dose to 88% with a second. In the US, 67% of 18 and over have received one dose, 59% have been fully vaccinated, and under 30 are the group most likely to miss that second dose, followed next by the 30 to 39-year-olds. So again, it's young people who are not particularly motivated. They're also busy, they work a lot, they have less flexible hours, they have caregiving responsibilities, but they're not coming in for second doses. So where does that bring us this week? This week, what we're seeing is we saw, just as a reminder, last winter, we saw spikes in vaccines. We were seeing over 3,000 deaths a day, if you recall. Then we saw the vaccine rollout be pretty effective. And then we've seen a dramatic decline in cases through the spring and into summer. And for the first time in the last month, at last maybe a couple weeks, we're seeing an uptick in cases. So we're up about 31,000 cases in the last week or so. And that raises some interesting questions about where we are and where we're headed. How this is being talked about is that this is a pandemic of the unvaccinated. Now, when we talk about the efficacy of vaccines, it's worth noting that the outcome efficacy set up by Operation Warp Speed was that vaccine manufacturers had to show that a vaccine was at least 50% effective in preventing serious illness or death, which was defined as hospitalization, serious symptoms, or death. It was never designed to measure asymptomatic transmission, and it was never intended to prevent or measure its ability to prevent mild symptoms. And the vaccine is a huge success in terms of declining deaths and declining hospitalizations. There's no dispute of that. What we're seeing right now is what has been called the pandemic of the unvaccinated. So 48% of those not fully vaccinated or not vaccinated at all said not only are they at higher risk of hospitalization, but that they're not concerned about the Delta variant. And when you compare it to people who are fully vaccinated, 72% of people fully vaccinated are very concerned about the Delta variant. So not only are the people who are most vulnerable to the worst outcomes of infection the least concerned, it also, when we come back to that perception of how serious is this disease? Am I worried about getting it? That's where those perceptions really matter. We're averaging about 26,000 new cases a day, which is up about 70% from a week or two ago. And hospitalizations are up as well, 36%. There's currently a travel advisory not to go to places like Missouri and Florida because community spread is so wide there. And sadly, deaths are also up to an average of 211 per day, which is a small slice of where we were last winter, when we were 3,000 deaths a day, but it's not nothing. Every person matters in that group. Over 97% of those who are currently hospitaled for severe COVID infection were unvaccinated. And so we know those outcome measures around vaccination were successful. So we come back to what are these perceptions of risk, and and who's afraid of what. And this becomes really important to think about. So thinking about whether or not you need to be vaccinated, it's really interesting that half of people who are unvaccinated in a survey in June said that the number of cases is so low that there's no need for more people to get vaccinated. And that's compared to only 39% of people who are vaccinated. We see that when we look at vaccine status, there's huge differences in who says that more people need to get the vaccine or not. So looking at vaccinated people, 7% said that the rates are too low to worry about anyone getting vaccinated, and 91% said people need to get vaccinated. And you can see those differences for people who are unvaccinated. So it's back to that question of perception. Are you afraid of this? Do you think it's important? And do you think it's a strategy we need to embrace? And then thinking about the same answer, should people get vaccinated, or are the cases numbers too low to worry about? Looking at the people who say that they want to wait and see if they're going to get the vaccine, or the people who say they're definitely not. So the hesitant versus the anti, you'll see the similar pattern about those perceptions of community spread and risk. You heard a great deal last week from Professor Hartley about variants, and I thought I'd be ill-advised not to mention, these are the top variants we're all watching. And I think what's really important for our purposes is that you can see whether or not the vaccines are considered highly effective or slightly less effective to these different variants. I appreciate that we are now referring to them as Greek letters and not by country of origin, but the last line of each column has where it was first identified. So Zeta was the one first identified in Brazil when we called it the Brazilian variant, if that makes sense to you. And we're just going to have to watch and see how well the vaccines continue to protect. What's important to know, we're talking about the Delta variant because this week it became the dominant strain in much of the US. As much as 87% of cases are tied to Delta. And what's more important about that is that it's much, much more transmissible because the virus replicates really successfully. So you have higher viral load, which means if you cough or sneeze or breathe, you just share more virus, which makes it more transmissible. But that doesn't necessarily mean it's more severe or more lethal. It just means it's more contagious, and which is why it's taking over as the dominant strain. But knowing which strains are the most virulent is really helpful. And what's a messaging challenge is to think about this as the virus is not quite the same virus it was in 2020, and that we have to think about these as different kinds of strategies. And most importantly, that the 40 to 50% of people who aren't vaccinated are the ones who are hosting variants, right? I've seen them recently referred to as variant factories, and I think that's worth thinking about. In terms of breakthroughs, we are still doing better despite our anxieties, we're doing pretty well. So estimates are 159 million people in the US have been fully vaccinated. And there's been about 5,492 hospitalizations or deaths of people who have been fully vaccinated. And so if you break that down, for those of you who want to do the denominator is 159 million, your chances, the statistical odds are still on your favor with vaccination. At the end of the day, though, we're going to keep coming up against this question of personal freedom versus community responsibility and how we want to balance these things. I was reading an article today, and a young person was saying, "Oh, I don't object to the vaccine. I object to the government telling me what to do," which is so interesting when we have no vaccine mandates at this point. And this is the kind of tension we're seeing, and we're seeing it amongst young people in particular. As a reminder, our origins of vaccines and the ability to have mandates originates from the US Supreme Court in 1905 and a challenge to laws that required vaccines against smallpox. And the important parts remain the same. Society based on the rule that each one of us is a law unto himself would soon be confronted with disorder and anarchy. Real liberty for all could not exist under the operation of a principle which recognized the right of each individual person to use his own, whether in respect to his person or his property, regardless of the injury that may be done to others. In the end, our risk of infection and our ability to prevent it is tied together at a community level. And yet we're going to continue to see challenges, not just against vaccines, but against non-pharmaceutical and medical interventions too. And I think we're going to be seeing a lot of that going into fall and winter. Real quick, I wanted to show you some data on mandates because I think it's pretty interesting. When you ask people, do they want a mandate against COVID in your workplace, what you'll see is the very dark blue is my employer already has one. The green is I don't want one. And the lighter blue is I want my employer to have a mandate. And unsurprisingly, there's a huge partisan divide on this question. And if you're already vaccinated, you are more supportive of having mandates than if you are unvaccinated. So 92% of unvaccinated people don't want to see mandates. The pattern holds true when we look at should we have mandates for college and universities or K-12 education. And you'll see almost identical breakdowns in terms of party affiliation predicting it. And if you are fully vaccinated, you are in favor of mandates. If you are unvaccinated, you are not. For those who are most affected, interestingly, 58% of college students say they would like a mandate. Parents of children under 18 are less convinced that they want mandates, and those who don't have children would like to see mandates in schools. And that's sort of giving us some sense of where we're heading into, I think, into the fall. I looked at my slides from a year ago. Here are the things I was worried about a year ago, that if we had a badly managed COVID vaccine, we would see declining interest in all vaccines. And sadly, that is what's happening. We are watching declines in childhood vaccines across the country. And we've also seen things like states moving towards forbidding messaging about the importance of childhood vaccines, which is unfortunate. Next month is Immunization Awareness Week. So we're going to see more of that and this kind of partisan churn around vaccines. I was worried that our expectations may be unreal and that this vaccine may end up being more like a flu vaccine than a polio vaccine, and that immunity might wane and we might need boosters or additional doses to create. And I think that's where we are. And that last year I said I was worried vaccines would become partisan, and I really wanted to come here and tell you this year I was wrong, and here's where we are. So my worries for 2021, because that's who I am. I'm the optimist who believes you should have a snack and a jacket at all times. That the partisan divide may prove to be lethal, and it's already showing so. There's some signs. Fox News turned the corner and is starting to promote vaccines. The governor of Missouri came out this week and said he's been vaccinated, so we may see some changes. The overpromise remains real, though. People want realistic assessments of what the vaccine can and can't do. And we have to keep messaging that not dying is a really important goal. But it's not going to be like measles or polio where you get it once in your life or 3 times in your life and you're done with this vaccine forever. We also need to be transparent. Like, we may not be collecting adequate data about asymptomatic post-vaccine infection because it's not that interesting to the CDC, and the CDC has made the decision to only collect data on breakthrough cases that are related to serious illness, hospitalization, and death. And that is our outcome measure. We need to be clear about that. And I think we are underselling or under discussing how little we know about long COVID and how significant that is as a long-term health outcome for children and adults. And we need to start talking more about the long-term outcomes of infection that are beyond you survived it or you didn't. There's a lot in between. And then there's path forwards. Let's ask good questions. Let's demand transparency. Let's support efforts to help those who are the most vulnerable. And the CU Denver has done an excellent part of partnering with a bunch of community organizations around vaccine equity. And we are continuing to offer vaccine clinics on our campus. And we have to remember that not all people who are unvaccinated are anti-vaccine. Some people cannot be vaccinated, some are too young, some don't build an immune response, and we need to think about taking care of everyone around us. And I'm going to stop there so we have time to talk. Thanks so much.
Thank you. That was really, really great. I have so many questions, but I will open it to our audience here. Yes, you're getting claps across the board. So
the things we didn't know how to do on Zoom a year ago, and look at us now. We have.
I know, right? We're pros. So I think we're small enough that if people want to just raise hands or just open their faces or ask a question, please go ahead. If you're more comfortable putting a question in the chat, you can do that. So I'll open it up to our participants. Yes, Kate.
I was just wondering if the countries that have more of a collective culture are getting more of their population vaccinated.
Yeah, it's such a great question. So when I started writing about vaccines and my book came out in 2016, I really thought this was like American exceptionalism. And then I started getting calls from journalists in other countries who were like, oh, it's the same in Germany. It's the same in the Netherlands. And I kept thinking it can't be the same. You have better healthcare systems. And I think the distrust of global pharma is important to keep in this mix, right? That global pharma and the distrust of partnerships between government and corporations has spanned countries. The other challenge we have, though, is that the US, because of how we threw money at this early, has had the best access to vaccines. And so you think about a country like Japan, which has, I think, 6 to 8% of their population fully vaccinated going into the Olympics. And that's a country that's fairly wealthy with excellent healthcare systems and who hasn't had access to vaccines. So there's interesting permutations. I did see that Macron today threw down and basically said, I'm sick of people risking my life and others by not getting vaccinated, and they are enacting new laws about how you can access public spaces if you're not vaccinated, and what you need to demonstrate. And that is, I think, a much more communitarian response. I will also say Macron gave a speech last week asking everyone to get vaccinated, and 3 million people tried to log on simultaneously and crash the appointment system, but 1.3 million people in 10 minutes made appointments. And I thought that was so sweet from the American perspective, because I cannot imagine any politician making a speech that would inspire 3 million people to make an appointment the same day, right? So there's a different kind of either respect for expertise or process that we're seeing play out in other countries, but it's not, every country has an anti-vaccine movement and there's a globalizing of information, but it is definitely the messaging and trust is playing out in different ways.
Larry, I think you had your hand up.
No, I was trying to figure out how to get my clapping off my screen. Sorry.
Okay. Other questions?
Marjorie, I think there's one in the chat.
There's one in the chat. Oh, that's just the video link.
Oh, I see. It's to me then. Okay.
Yeah.
So Laurel, do you want to ask it or do you want me to read it?
Oh, I don't. Oh, it's to you directly. I see.
I was just I saw a news story today about unvaccinated nursing home workers and a rise in cases, even in vaccinated elderly people. And I was just wondering if you think more hospital and healthcare systems will start requiring vaccination of their staff, and if so, how much of an impact would that make?
Yeah, it's such a great question, and Colorado is abysmal in how we handle long-term care facilities and nursing homes early pandemic. And so there's a lot at stake in this question, because we know seniors who have high rates of vaccines don't build immunity as well. Their immune systems don't learn as easily. And so they're still vulnerable. And that matters. We also know there was a recent study to suggest that it wasn't just vaccine, not vaccinated nursing homes, but the number of care providers mattered. So places that have more part-time workers and more transient workers across multiple sites had the highest rates of COVID infection. The question of mandates in workplaces is really interesting for healthcare workers. And it's, since flu vaccines have been required for a long time in most hospitals, there's a pretty good precedent for thinking about this as important. The question I think becomes with a virus when community spread is so huge is where else do we want to see mandates? Where else do we see that we're encountering lots of people and we feel responsible to make sure that showing up for services is not increasing your risk? And I think those are the places where mandates matter. There's good evidence from childhood vaccines that mandates do increase vaccine rates, and that the harder it is to opt out, the less likely people are to opt out, if that makes sense. So Colorado is the most permissive state in the country for opting out of vaccines. And as a result, we have the highest use of exemptions and amongst the lowest rates of childhood vaccines in the country. Even just changing the documentation requirement seems to help increase vaccine rates. And so I think we can think about both, do we need to mandate it versus allow exemptions to be really easy? And then what are the settings in which that's important?
So a question from Tracy in the chat. If we have family members that are deeply invested in having an anti-vax identity, is there anything effective we can say to them or any data we can share to try to make a dent in the misinformation they've received?
Yeah, I tend to, like in my work, focus the most on what we call the vaccine hesitant, the people who have not dug their heels in yet, but aren't convinced, because that's the most persuadable group who's most interested in a conversation. For folks who, I guess it depends, right? Everyone has to figure out their own Thanksgiving, figure out their own comfort level in these conversations and how to handle relationships and what the rules are in your house. I was just talking to someone who has a parent who's adamantly opposed to vaccines, who has a child too young to be vaccinated. And they said, we really want to visit, and here are the parameters. Like, there will be masks, we will be outdoors, we will set the rules to make this relationship possible without the confrontation. In general, it turns out telling people statistics never helps. Telling people they're anti-science or ignorant has never persuaded anybody. The things that tend to work when they do are sharing, here's how I made the decision, here's the things that were compelling to me, or here's the reasons it's important to me, and personalizing it in a way that matches the way we all think about health anyway. And sometimes it's just continuing the conversation, right? Just making the conversation available. But in general, unfortunately, there's no examples in public health of someone being told that they're stupid and having that inspire them to change their mind.
Yeah. Larry.
I noticed yesterday the Washington Post ran an article where a federal judge upheld vaccine mandates for Indiana University. And so I started thinking, CU Denver doesn't have a mandate, we've got a requirement. Is that different? And then do you know of any other court decisions that are upholding vaccine mandates for organizations or healthcare systems or universities?
Yeah. And so, thinking about this is really important, right? Because I will be the first to say that as much as I care about community health, I never want to be the person who's like, everyone has to do everything in lockstep, right? Because we know that those are the kinds of dynamics that extinguish diversity and richness of beliefs and things that matter, right? So thinking about how that fits into our institutions is really important. The underpinnings of vaccine requirements is the logic that if we're going to require children to attend school and put them in a schoolhouse together, that practice, that legal mandate should not increase risk, right? So we require vaccines to make sure that us legally mandating education isn't harming people. And that's really the underpinnings. And it's worth noting that in the US, our modern vaccine requirements have only existed starting in 1968. The last states came on board in 1981. So they really haven't been around that long. And they were very much intended as a social justice campaign that when we require them, we take care of the vulnerable, but also it increased federal funding. It made money available to states to roll out vaccines broadly. When we get to universities, it's a little bit different because you're not entitled to a university education and you're not required to attend a university. So universities have a little more latitude in deciding their policies. What we're doing in the fall here thus far is we have a mandate or a requirement, and they're pretty interchangeable in terms of words, but we live in a state that allows religious and personal belief exemptions. And thus we are allowing religious and personal belief exemptions for our faculty, staff, and students who would like to not be vaccinated. Having said that, that's not a blank check, right? That there may be parameters. And so, we're going to have to see, I think in the coming month, what the process is going to be, but we know it's going to require regular testing. It's going to require mask wearing, and it's going to have different requirements for infection containment than if you're vaccinated. And that's part of contributing to public health in ways that may feel relevant.
And we don't have much of that information yet, right? I mean, the decision makers at CU are still trying to figure out what that's going to look like.
Yeah, I mean, it sounds like these are like this is sort of the high altitude view, but then, to think about how are we going to do this? So are we going to have people checking? Do you have an app on your phone? What do you show each day to show that you've registered your vaccine requirement? Like you've uploaded your card or you've uploaded your data. Where will it be housed? Who will be checking it? I don't think there's a plan to put holds on registration in the way that we do for, say, an MMR or other things. But thinking about, what does it mean to get access, to continue to make it available, and to not make being unvaccinated easier than being vaccinated, right? Which is also the challenge for childhood vaccines too, is to not make doing nothing easier than doing something.
Right.
I think they've announced the end of this month, the beginning of late July, early August, they're going to announce a process for registering if you do not, and you do have to officially waive out. Doing nothing is not one of your choices.
So at the governor's presser today, he announced that they were giving, I think it's the state is giving out $100 gift cards at Walmart for getting vaccinated. And what are those kinds of incentives? I mean, I've heard of other things like that, in other places. And do those work? I mean, are they?
Yeah, it's such a good question. So, so the governor announced today at the press conference that there will be $100 gift cards to Walmart if you show up to be vaccinated. And I'm not sure if Walmart's donating these or the state's paying for them, but there is state money that's going towards this because we have all this federal money for COVID response. And then I also saw that the community colleges are partnering with the Amazon Community Fund to offer a drawing for scholarships for community college students who are vaccinated. And there's a couple of good questions. So one is, should I have waited to get my vaccine to have been eligible for $100, right? So have we created now a disincentive? Like, should we all wait to see if it gets better, if the offer gets better over time? So it creates odd incentives for future public health interventions. Mostly what's really interesting is all of these schemas of like reimbursing people to create incentives don't work. Some states have tried like free fishing licenses and nobody did it, and what's really interesting is that people who study decision making and game theory point to, if you assign a monetary value to the reward, you've essentially equated the vaccine as having a monetary value, right? And so now it has a price tag. It's worth $100. And sometimes you've also increased the perception that the vaccine is not the reward. And therefore you are trying to pay somebody to get it may actually undermine their confidence in the vaccine. Like, if it's so great, why do you have to pay me to get it? And so I don't trust it. Colorado was also one of the states that followed the lottery. We gave away $5 million in lottery funds to anyone who was vaccinated. And it did nothing to increase vaccine rates. It was largely unsuccessful. It started with Ohio as the first state to do it. The goal was like, it's so much free marketing and free publicity, which it turns out it didn't really affect vaccine rates, but it sounded like it would. So it turns out that people tend not to make their health decisions around these monetary incentives. There's exceptions for sure of people who are motivated. I was just talking to someone whose father was motivated by a drawing for season tickets to the Lakers, so for some people there might be the right incentive if they're already open to it. But in general, it tends not to be the way people feel empowered around their health, and therefore may not be our best strategy.
That's fascinating. Other questions? Laurel.
I can ask one. One thing I wonder about in terms, I think that public health officials are tying things like mask mandates to percent positivity in the community, cases per 100,000. But also I know that there are considerations for what people will tolerate and what we might expect them to be, we might expect of the populace later. So we don't want to over ask now and not get compliance later. So those sorts of things. And I wonder if we were more explicit, saying things like, as soon if positivity goes up over this, or number of cases goes up over this, then in this school district, we require all students to wear masks. Would that help people? But maybe not. I'm talking myself out of my question.
Right, because
But-
positivity last week was up, and then they said, well, it's because of nobody got tested last week, and so the only people who got tested were really sick. So our positivity is, if we want positivity rate to be low, we would just ask everybody to get tested every week, and then we would, right? So the denominator is complicated in the positivity rate, and typically, we report positivity because once we get over 5%, it becomes a marker of there's a lot of community spread we're not seeing, right? Like it's sort of a yes or no kind of thing. The number itself is important without a strong testing framework. And we're at this, this threshold of like, what do we really want to know? So what if we have a vaccine that we know works really well against serious illness? Do we need to know how well it works against transmission between among vaccinated people who have like no symptoms or cold-like symptoms for a few days? Is that important for us to measure or not measure? And that is not a scientific question. I mean, it's a scientific question in design, but it's a human question of like, what are our outcomes that we care about? And we are going, I think it's widely accepted that we are not getting to zero, right? This is not going the way of eradication. And so what does it mean to coexist with viruses? And is that okay or not okay? And in my little corner of Twitter and of vaccine researchers in the world, this is an argument of like, can this be endemic or is this different? Can we not tolerate this? And what does that mean? And so these are hard questions that we're not having good conversations around, in my opinion. The other part, and so like my husband's a physician and he tells me I'm the most negative vaccine researcher in America, that I'm like not on the bandwagon of vaccines are always magic. Because I worry so much about this overpromise question. But, with masks, like it was, I think everyone agrees the way that the mask mandate was, like the CDC said, if you're vaccinated, you don't have to wear masks, was handled badly, right? It was very flat. There was no nuance. There was no real sense of like what this really means around community levels. Colorado 3 weeks ago announced that masks are not required in summer camps or preschools. And those are spaces that are 95% unvaccinated by definition. So the idea that we're not being really nuanced or thoughtful or empowering people to understand transmission, to me, is the liability, because people are accustomed to saying they want control for their own health prevention. And I don't think we've provided people, the fact that we still argue about aerosols versus droplets, and how much that matters makes it really hard for people to make informed decisions about their own risk containment and their own kind of harm reduction strategies. And I think that's where we have to move, is giving people, like, if you're indoor, if there's this much ventilation, like starting to let people ask those questions to make decisions about their own levels might go further than all or nothing on masks or all or nothing in these spaces. Because what I find in like a decade of talking to people about vaccines is people see themselves as experts on their own lives, and they want to be empowered and they want to feel in control. And we haven't given them any tools to do that. I would also say the history of HIV gives us some really good lessons about how we can start to think about harm reduction in ways that are livable. And I don't think we're there yet with COVID, but we need to get there.
Jennifer, am I right in assuming that the university does require some vaccines for all students and faculty on campus? Is that correct or not?
So faculty are not required to have any vaccines except for COVID in the fall. Students are at most universities in the country are expected to upload childhood vaccine records. And then there's also increased interest in requiring things like meningitis vaccines because they tend to have outbreaks amongst young people or in dorms or whatever. And then it just depends on whether the state allows exemptions or not,
Okay.
based on state laws and what the universities do around those exemptions. So that's what we do. We require vaccines and we allow exemptions.
And is that across the board for all kinds of vaccines?
Yeah.
Okay.
We could have
Thanks.
a conversation about flu vaccines. Like, we've never required flu vaccines, which until COVID was the leading cause of death of vaccine preventable diseases. And there's no support for requiring flu vaccines.
Right. Well, thank you so much. This has been really informative and well presented. So